I think wants to say a few things first.
So the exam is Tuesday morning, large auditorium, start at 8 o'clock. 80 questions, all renal. 2 hours and 45 minutes for the exam with a 30-minute review period when you're finished. Technically puts us outside of the schedule by 15 minutes, but I don't think you'll object to more time for the exam questions. And then you have cell and tissue at 1 o'clock, right? So you've got a little bit of time to get some lunch and clear your brains. What else?
Calculation
All
questions.
of the calculation questions will be grouped together, and they'll be identified as the first word of the question will be calculation in parentheses. So you'll know it's a calculation question.
And the reason for that is they may take a little longer, and they're all at the end, so that if you do run out of time, at least you're not missing a lot of questions, just maybe 1 or 2 calculations.
The exam will be up for downloading probably Sunday night, maybe Monday morning. Usual procedure. You don't need anything but your computer and your power supply. And cool.
Questions? No.
Oh, so the eye and ear questions will be on the cell and tissue exam. There are 12 of them Dr. Monaco asked for. So, and that's a 60-question exam. And he'll tell you about the time on that. I think you have 2 hours or something. Dr. Rowe's got a renal review now, which will probably go till noon. Rather than make you come back or stay too long, I'll just record a integrity review for the eye and ear and post that with the PowerPoint slides. Probably 6 from each lecture, hitting the highlights. Okay? So look for that this afternoon on integrity.
Will you both be available on Monday for questions?
Yeah, Monday.
Yes.
Yeah. Yes.
An email over the weekend, for me anyway.
Yeah, I won't be able to answer your questions over the weekend, but I'll get to them Monday. Okay?
Is there a lot of calculation questions?
About 8 or 9,
10.
10 maybe.
10.
10.
And then they are at the very end of the test?
Yes, yes. So the concept here is that if you spend 20 minutes on a calculation question at the beginning, and then another 20 minutes, you might miss 30 questions. So the idea is that get the first 70 questions answered relatively quickly, and then if you get stalled on the calculations, at least you're only missing 1 or 2, okay? Because they all carry the same weight.
Now that sounds scary, right? 20 minutes per calculation question. I can tell you,
I meant 2.
in past years, no student has said they spent 20 minutes on a
Okay.
Dr. Rowe calculation question.
I'm just slow. Okay. Well, and maybe they just didn't admit it. It shouldn't take that long. It shouldn't, really. Also, I was asked for a list of equations that I think you kind of need to remember, and they're up on D2L. Okay. I almost hate to do that, but I mean, there is no doubt that the STEP exam absolutely expects you to know the formula for clearance, and a few others too. And like I said, they have tested on the Fick principle, etc. So look, what the plan is here is that I want to try to really motor through this, hit the highlights, and then we can have some questions afterwards. And if you've got any more questions on acid-base, I'm happy to stick around for a while and we can answer those. Okay? I would suggest, but this is up to you, you are the paying customers, I would suggest no explanations as I go, but if something I've said is not clear, raise your hand and say, what on earth did you mean, Rowe? Okay? Or something like that. Okay, good? I didn't bring my advanced. So, first lecture, basic renal processes. This is all very basic. I'm not going to ask you a question that says, what is the normal renal plasma flow? But I think it's always useful to have a feel for it. You need to know what the filtration fraction is. Oxygen consumption, basically what this means is that you really need to understand that oxygen consumption relates to the amount of work done in the kidneys, which is mostly reabsorption and secretion. Perhaps it looks sarcastic. You need to know there are two types of nephrons and the long loop. The long loop is good at conserving water, and you really don't need to know a lot more than that. Okay. Next, understand that backwards. Okay, Starling Forces. It's kind of a no-brainer. Fluid. I think you should remember total body weight's about 60% water, and it does vary with gender, with age. And I think it's useful to understand the 20-40-60 rule. I mean, it's not like I'm going to say exactly what is the relationship quantitatively between ECF and ICF, but I think it's helpful to have a feel for it. Know all of those. I've tried to reduce that to the lowest possible number, but the boards expect you to know how each of those substances distributes in body fluid compartments. And so undoubtedly there will be a question on that. Remember there was a formula for estimating osmolarity. I don't need you to remember that. But if you understand everything on that page, I think you'll be good. Oh, this is easy. Be able to do a Darrow-Yannick diagram for any fluid disturbance. Okay. Probably in simple terms, just understand the difference between normal saline and 5% dextrose. Know when to use them. Understand the distinction between resuscitation and replacement. In other words, is there a case for giving a fluid that will preferentially fill the ECF, and that would be isotonic saline? And remember, if you go back to the Mr. Good case, you'll get some feel for that. If you have a critical fluid loss, you have got to get the plasma volume back to where it should be. Be able to do that problem. It's Costanzo. That'll take a little extra time, okay? And it is at the end of the test. Oh, there is a question on that, by the way. Look, I promised you this. Not that I get terribly excited about it, but I know that step exam questions come up on this. The proteins, well, this everybody knows how to do. I don't use these terms, isosmotic, hyposmotic, because I find those confusing. But given a disturbance, these you can all do with the Darrow-Yannick diagrams, but you need to be able to add a level of complexity. The plasma protein's easy, the hematocrit not quite so much. But I will set you a test question on that because I know it's come up on the step exam. Be able to manipulate Starling forces, understand net filtration pressure, be able to do calculations. There are often calculations. They're on the step exam, and I'm sure that I've set one too. Pretty sure. So this is directly out of Costanzo. You need to have a feel for what happens when you constrict afferent versus efferent arteriole and what it does to the glomerular capillary pressure and what that might do to the GFR. In other words, if you squeeze the efferent arteriole, you could actually get an increase in GFR. could. It's not much that's testable there, but I think you do need to understand that the oncotic pressure rises to a point where there's a filtration equilibrium. So, you know, I can't test you on the complexities of that, but understand that that's something that happens. First of all, know that order regulation happens and realize that something has to happen to the resistance in order to maintain constant flow. In terms of the exact mechanisms, we don't have a clear idea. I think you should kind of understand the concept of tubuloglomerular feedback. Test-wise, this is kind of hard to test. This is easy to test. And although this is just rote memorization, you know, remembering what constricts and what dilates, obviously it's important that you know some of these things. So, you know, that's the sort of thing that is easily testable. Oh, and like I said, tubuloglomerular feedback, don't know the fine mechanisms, but just understand what the term means. Renal failure divided into three, and we introduced some terminology, and I think you should understand that terminology. I mean, after all, 3 or 4 years from now, you will need to know that terminology. Probably the most important thing is to be able to distinguish between pre-renal failure and intrarenal or post-renal failure. Too fast, too slow? About right? Okay. This may seem the sort of thing that you shouldn't know as an M1, but it's very testable on the boards. Okay. And I don't mean to be cynical. I think it's kind of important that you understand how charge affects filtration. Okay. I've also got a comment here, how to measure. Understand the ways we measure protein, albumin to creatinine ratios, understand why that's important and how it's a good measure of proteins in the urine. It's kind of hard to test this directly, but the shelf people, the board people, absolutely want you to know about what happens when people age. So the only thing to really take away from this is that as people get older, their GFR falls. And there are some gender differences. It's hard to test that in any in-depth level. I think that this was at the beginning of the lecture, and I think this is a good summary. It's a good place to, you know, you could use this as a concept diagram. But basically know what's moved and where, and have some idea of quantities too. I mean, I don't need you to know the exact quantities, but you know, 2/3 of the work for most things is done in the proximal tubule. The loop is kind of special, as I hope you've figured out by now. And then a lot of the regulation of things happens in the distal nephron. Okay. The whole bunch of these diagrams, I told you how excited I got by them, and I don't know how you got whether you got excited about them, but if I throw any one of these cells at you, you kind of need to know where it is in the nephron, okay? So it's kind of a way of testing to see if you know what goes on where. I mean, the fine detail maybe not, but you need to have a good feel for what's going on in which part of the nephron. Always testable, that graph. SGLT, I guarantee you I'm going to ask you some questions on SGLT1 and SGLT2 because this is becoming clinically so significant that I think we should be asking you questions on it. SGLT2 inhibitors are becoming more and more and more significant as time goes by. So we'll test it. What does this say down here? Also similar diagrams for other substances. You're going to be doctors. I think you should all understand about renal protection and the things that might protect the renal system. I do have a test question on this, but it's really just understanding, given a certain situation, understanding how the Starling Forces change. Okay, so it's not like you have to remember anything. You just kind of have to figure out what might happen to Starling Forces given a certain change perturbation. Those formulas are on that list I gave you. Absolutely, any renal physiology exam will have a calculation on clearance. And I also promised you that I would do a FIC calculation for you, or have you do one, because it has come up on the shelf, on the boards before. So that's basically just to get you prepared. Clearance of various substances. Know how they change with plasma concentration. That gets tested a lot. The one that's the most confusing is that as you increase the plasma concentration of PAH, the clearance goes down. That's one that confuses people a lot. Do not be confused. So you could memorize it, or you could actually try to figure it out. I would much prefer you try to figure it out. That relationship is obviously very important. Where we took this from here is that we developed the idea that the BUN to creatinine ratio stays around 10 to 15, or between 1 to 10 and 1 to 15 in renal failure, but in dehydration that ratio can get bigger. And so certainly there will be test questions, or at least one, that asks you to deal with that concept of the increase in the ratio. Okay. Not that I need you to understand the way this diagram's set up, but understand how these parameters, particularly the urine osmolarity and the fractional excretion of sodium, change in these two conditions, pre-renal failure or acute tubular necrosis. Okay, and you're going to get a fractional excretion calculation, right? Okay. Whole bunch of calculations. Obviously, fractional excretion of sodium is important. Fractional excretion of urea is important. But this is in Costanzo, and I know that I've seen questions that ask you to calculate reabsorption rates, secretion rates, and the such like. It's not terribly difficult, and realize you just have to jump through some hoops and be able to do that. And probably once you get through step one, you'll never do it again. Concept diagram, I think. Once you've been through everything, I think that should all make sense to you, and I think you need to realize what's detected where and how things change. Okay, And finally, this concept of effective circulating volume, and I think, what does Costanza call it? Effective arterial blood volume. Critically important for you guys in the future. So and because a lot of the things that you're going to be doing revolve around trying to deliver blood and oxygen to the tissues. So understand that concept. Just know it. This is maybe even more important. I mean, obviously you need to know what angiotensin II does, and that's kind of a no-brainer. But remember, I put a lot of emphasis on this renin-angiotensin cascade, mostly because we have at least 3 major drug classes that interfere with that system, and they're primarily antihypertensives. So, and the way this has been tested at the step exam level is that they'll say, gosh, what would happen if you had an angiotensin receptor blocker? What would happen to the levels of angiotensin I? What would happen? It go up. What would happen to the level of angiotensin II? It would go up also, yeah. So, it just asks you to rationalize. It's basically asking if you know what it does where. Okay. Okay, then each of these substances. I think understanding potassium balance and what changes it is important and testable. This was mostly for your information. I mean, I think you should be able to do fraction excretion of potassium if you're asked, but this was mostly just so that you understand the concept that you can either secrete or reabsorb potassium in the distal tubule, distal nephron. Understand the general patterns for all 3 of these. That's calcium, magnesium, and I think, yeah, the other's phosphate. Okay. I actually meant to change this. I don't know why, but it seems like the boards are pretty big into testing things that affect phosphate excretion. So even though that's just kind of looks like a lot of picky detail, pay attention to it.
Dr. Rowe?
Yes, ma'am.
On the phosphate, calcium, magnesium, how important is it to know exact percentages for each one?
So the question is, do we need to know the exact percentages?
Like for each part of the nephron?
No! I will be happy if you say, calcium, it looks like most of it's in the proximal tubule. Okay? Oh, quite a bit in the loop too. Wow. And the regulations in the distal nephron. That's kind of the level that I want you to know. This is an important concept. Understand how secretion is governed by tubular flow. It's critically important in clinical medicine, critically important in understanding kidney disease, and understanding why you might get hyperkalemia or acidosis in kidney disease. I actually gave you a different diagram that I followed up on this. That was mostly for information. I'm not going to test all the details, but that was just mostly for your understanding. But you know you have to be able to do these calculations, yes? It's on the list. This type of question is game. It's designed to in some ways I'm kind of simple. I just like to know if you know whether something's secreted, but dealing with this concept of tubular fluid to plasma ratios, you should probably have a good feel for that. in my mind, it's kind of a vocabulary thing. I'm not sure it actually imparts any greater understanding for renal physiology, but this is kind of the way it's been tested in the past. So try to get your teeth into that. Water regulation. Like I said, I think it's helpful to understand the numbers so that you understand the system. That's pretty untestable. That was for your edification. That's testable. This is urea. Know where it's reabsorbed, where it's impermeable, and how it all fits together for urea cycling. The thing that confuses everybody with the vasorector, this is a capillary. It's all passive. And people are always looking for transport processes. There are no transport processes. It's passive. It's a capillary. It's a rather unique capillary, but it's capillary. ADH. Certainly know the first two there. First two actions, water permeability and selective urea permeability. Understand the basics of what's going on here. Realize that this is a principal cell, and the specialized principal cells in the inner medulla also have an effect on urea permeability. So probably two slightly different types of cells. This is always testable. I mean, probably these are not terribly important, but you absolutely have to know about these two stimuli, osmotic stimuli and volume stimuli. And realize that there's differences in sensitivity and differences in responses. Darrow-Yannick diagrams. I think you should be able to work with all those. This is a harder concept. Try to get to grips with it. Don't you love acid base? I'm not even going to look up to see if you're nodding. Yes, ma'am.
Will 6.1 always be?
Yes. It's the pK of this reaction here, and so it's always 6.1. So it's a constant. If it's 6.1 today, it's got to be 6.1 tomorrow. And I don't mean that to sound facetious, but it's a constant. Obviously, you need to understand the top equation. I mean, I'm not going to ask you to reproduce it, but it's so seminal to everything that we do. And I've said before, I'm not going to make you work with this equation, but my gosh, you should understand the form of it. I think I put it on that equation list, and I think I made a comment that I'm not going to ask you to remember it and plug things into it, but my gosh, it's so critical. Not so much all the details, but if you can, and I know this was hard, but get to grips with the idea of reabsorbing bicarbonate and conserving acid, and then the different situations where you're actually trying to get rid of acid, and understand how the mechanisms work. They kind of use the same machinery, but they work a little differently. Okay. One thing that people struggle with is the idea that getting rid of acid always adds new bicarbonate to plasma. So if you get rid of acid, you have to have this balance has to be right. So you get rid of this, and that has to go up. Okay? Yeah, same thing. I'm not going to test on the details here, and I really can't test on the general concept, but at least understand that the proximal tubule generates ammonium from glutamine, and realize that in an acidosis, that glutamine synthesis can be upregulated, and it's a significant part of getting rid of acid. I can't easily test you on the concept, and I'm certainly not going to test you on the fine details. Got to be able to do that though. Net acid excretion. You might even be doing it again in 5 or 6 years' time. You've got to be able to analyze blood gases, and I think this is fairly straightforward. I mean, just using this straightforward approach gets you most of the way there. So the way a lot of questions are set up is, what's the primary disturbance and what's the compensation? Or is it compensated? These are things that, if you go through this process, I think should be relatively straightforward. That's more informational than anything else. You got to know what that is. And you should also know which of those common conditions are increased anion gap and which are not. Okay. Same thing. Oh, yeah. Okay. There's a lot more that you'll learn later on, but I'm trying to keep the list brief. Same thing here. There's a lot more, but I'm trying to keep the list down to the most common conditions. So Mr. Good, everything that I had you do for Mr. Good is game for the test in some form, fashion, or another. So that wasn't just to make you miserable, okay? But did it work? Sorry. Okay. No, honestly, I'm really trying to do that for your benefit, because in my mind, doing calculations and working through quantitative concepts is really kind of important, because the nature of renal physiology is that you do have to work with concepts and calculate things. And so the more practice you get, I think the better it is. Okay. Oh. I think that's it. So, so the way we should work from here is, first of all, do you have any questions about the exam? Because that's what it's all about, isn't it? If there are no more questions about, oh, okay, so let me, I think I've already said this. I am not going to be here at the weekend, but I will get on to all of your questions by Monday. All of your email questions I'll get to early Monday morning, and if you need to come see me, I'm around most of Monday, okay? What else was I going to say? Anything else I need to cover on the test? Okay, so if there are no more questions on the test, If there are things on acid base you want to cover, is there anything that everybody agrees that we need to go over again on acid base? I mean, I would prefer just to work with you individually, and I'll stick around a little while here, just in case you have any questions. But do you think there are any things that everybody got confused on that I need to go over? No? Okay. So why don't we stop at this point, and I'll stick around for a little while in case you've got any questions. Okay? I'll stay here for a while, and then I'll be upstairs for a little while before lunch.